Now, all four of the speakers scheduled for this session have spoken. We have about 22 minutes still at hand to address questions. So, to begin with, Jessim has a couple of questions which relate to vaccination. The first is, what explains the fact that the vaccination centers are not as crowded as expected, especially the vaccination centers run by government? And the second is, whatever happened to the Indian Covaxin? Everyone I have come across has received Covishield. So maybe uh, Pravir, Satyajit, Indranil, all of them can chip in and responding to these questions.
I think that's a Satyajit question. He should feel that.
Okay, Satyajit.
Now we know who is the Virendra Sehwag here.
So the first question I'm going to leave to Indranil to address, because it's very much a question that relates to public perceptions of healthcare delivery, including vaccine hesitancy, vaccine anxiety, vaccine cynicism, whatever one calls it. So I'm going to leave that one for Indranil, and I'm going to go to the second question because that's a straightforward issue. So there's a technical component to that response, which is the difference between how Covishield and Covaxin are designed. I talked about the platform, the technological platforms. Covishield is in the category which delivers the genetic code for the spike protein into the body. It does so by putting it into a harmless adenovirus. In the case of Covishield, a chimpanzee origin adenovirus. But essentially, that chimpanzee origin adenovirus, when injected, provides the COVID-19, the SARS-CoV-2 spike protein genetic information to the body itself, and the body makes the spike protein and responds to the spike protein. This is therefore at the production level, at the large scale, a relatively harmless technology. You're making adenoviruses, you're making large amounts of adenoviruses, but these are harmless adenoviruses, and therefore you can scale up manufacture quite easily. Covaxin, on the other hand, which is the ICMR Bharat Biotech technology, and I was hoping that we were going to come up with why have all vaccines, 90% of the vaccines across the world, including in India, been developed in the public sector with public sector funding and been transferred to the profit-making private sector for manufacture. But that's a separate issue. The ICMR Bharat Biotech Covaxin is essentially growing the natural virus, SARS-CoV-2, the COVID-19 causing virus, in large amounts. So it is an infectious virus. Then the virus is purified and inactivated. So once it is inactivated, it is safe to be injected into bodies as a mimic to generate an immune response. But in the manufacture process, you are therefore expecting the manufacturing technology to work at large scale in manufacturing huge amounts of infectious virus, which means that safety and containment during manufacture become a major issue. And as a result, making large amounts of infectious virus is always going to be a much more problematic thing to scale up in manufacturing terms than making a relatively harmless virus such as the adenovirus. It's therefore no surprise that Serum Institute of India can massively scale up an adenovirus-based vaccine technology platform, whereas the Bharat Biotech enterprise cannot scale up over exactly the same accelerating trajectory the manufacture of Covaxin. And therefore, it's not surprising that there is an enormous disparity between the supply of Covaxin doses versus the supply of Covishield doses. Now, this is not the only reason, but this is a major reason, and this is one of the many issues that I thought we should incorporate as technological underpinnings of what is essentially a technosocial issue. The first question, as I said, I'm going to egg Indranil to respond to.
Okay. Thanks, Satyajit. Yeah, I'll make two points. One is a personal anecdote. I was in Calcutta and I was with my parents, so I took them to a public hospital in a suburb and for the vaccination. We saw that there is like overwhelming crowd. People, this is in a suburb which is extremely densely populated, well-functioning secondary care facility, huge crowd. Then I went for surveys in Kolkata Municipal Corporation and municipal hospitals. We saw significant crowd in all of this. The point I'm trying to draw here is in places where public systems are historically stronger and there is a history of taking care in the crisis situation, people have better trust. Definitely people are going to these facilities. You know, if we look at the numbers overall, less than 30% of the vaccination till now are happening in private sector. More than 70% in the public system, though the numbers of hospitals enrolled are double than the public system. 20,000 private hospitals vis-a-vis 10,000 public hospitals. But then the other point I want to make very quickly here is that beyond the metropolitan cities, the capacity of private sector hospitals doing vaccination is very limited. They will not have the refrigerators, ILRs properly in place to store vaccines. And there would be also some bit of lack of training in nurses to do the vaccination adequately, though that may be a lesser significant issue. Large part of other routine vaccination in the private sector happens only in the metropolitan cities or bigger cities. And it is only limited to top 10-15% of the population. So vaccination and private facility, large part of the country cannot associate with. So they would go to public facility. Of course, the cities like Delhi are very different. In fact, Bombay, which has a strong municipal health system, albeit all the reforms and declining quality, that would still attract more people towards public system, I suppose. Thanks.
Thank you. Robbie, do you want to add something?
No, I don't think I need to add anything to what has been said, but it is possible that because a lot of it was thought to be through the COVID app and people had to book, so a lot of the people who are not so familiar, and particularly my age group people, even with my phone, I find all of this rather difficult to use at my 74 years of age. So I'm wondering how much of that has also been a bit of a showstopper. Though, of course, you can walk in and stand in queue and hopefully you'll get a vaccine still.
Can I add one small point here?
Okay.
It's very, so again, this is anecdotal evidence, but you know, it is still a very middle class educated section phenomena that going to the public facilities for vaccine. The poor are largely unaware, they're not able to deal with this, and they don't, in fact, there is also the hesitancy part, so this might exacerbate some of the inequalities that exist in the society. We might see the numbers, we don't have numbers to back this up, but I'm just sharing as an anecdote.
Surajit, if I may.
Yeah, but Sachin, before you speak on that, because there's a related question that Vikas has.
Sure.
I'll just, we could also comment on that. His question is that there's a huge amount of experience we have of large scale vaccination in India, which works basically on reaching people, going to homes, door to door, rather than expecting them to come to vaccination centers. So is that a realistic possibility with regard to the COVID-19 vaccination also, or are we going to rely only on people coming to vaccination centers? If you could address that also.
So let me couple my response, and then I will hand it back to Indranil to talk about the differences between our universal immunization program, which is what we are talking about as our experience, and the different imperatives and needs of a COVID-19 vaccination campaign. But vaccine hesitancy has an additional feature to it. The Covaxin in early approval triumphalist nationalist imbroglio added to it. But there is a general narrative about how rapidly vaccines for COVID-19 have been developed. And a great deal of vaccine skepticism and hesitancy across the world in locally configured, locally culturally configured ways has focused on, if something has been made so rapidly, there must be something wrong with it. There must be shortcuts and so on and so forth. And the Indian government's triumphalist nationalist narrative has not provided sober, nuanced, clear information about what parts of the vaccine development pipeline have not been shortcut and what parts have been very carefully and measuredly shortcut. Instead, we've indulged in an official narrative of chest beating about just how rapidly we've made our own vaccine. And it's therefore no wonder that people have incorporated the speed of vaccine development into a skepticism of vaccines. So that's one issue. As a matter of record, let me point out that for the safety testing of vaccines, all vaccines, Covaxin included, there have been no shortcuts at all. So all vaccines are safe to take, and based on preliminary evidence, all vaccines will provide reasonable protection. But because we have not cast our messaging and narrative as a means of getting information across to empowered citizens, but simply as a drum beating or a thali beating, whichever you want to call it, we have a significant amount of vaccine skepticism consequences. That's one issue. The issue about outreach, door-to-door vaccination is, number one, to do with the scales involved, the time course involved. Keep in mind that the universal immunization program immunizes, Indranil, correct me, 7 crores a year, somewhere in that ballpark, and distributed throughout the year. I mean, all pregnancies don't result in babies in 1 month. So distributed throughout the year, number one. Number two, even in that, the bulk of the door-to-door component of vaccination is with the oral polio vaccine drops. Injections are much less door-to-door. There are some places where door-to-door injectable vaccination is being delivered, but that's a far more specific and contained component. Here, what we are looking for is an injection being delivered door-to-door. And so I will simply pass the buck to Indranil to explain the distinctions that are involved in response to Vikas's question.
Indranil?
Very briefly, so the more about describing this, we have what is called Village Health and Sanitation Nutrition Day, where the ANMs go to certain, say, Anganwadi centers, and mothers come to get their children vaccinated. That's one model. And then there is this special catch-up rounds which are done for polios, where door-to-door is also done. So that's the point I wanted to bring in. And I cannot agree more with Satyajit on this, issues of hesitancy. Yeah.
Okay, anyone else has any question?
There
Can
were
I
some.
just then ask a question to Satyajit, which is this, that is there some relationship between whether the profit motive or the public health motive works and the choice of technologies with which the vaccines are being developed? Is there some relationship there? And to Prabir, just one question. If you, according to the UNICEF data, the vaccine donations in the world, paradoxically, the largest vaccine donors in the world are China and India. Both countries which have very large populations to vaccinate themselves. Okay. But at least for India, the data is also showing that the donation amount is small relative to the exported amount, which is presumably for commercial purposes. So how do you see this? Is it that facilities in India or China, large production facilities for vaccine, are themselves going to serve because of, can vaccine nationalism or geopolitical calculations actually make these capacities get used to democratize vaccine access across the world? Or is it going to feed into the advanced countries monopolizing most of the vaccines? So Satyajit first and then Praveen.
Okay, so let me give examples of what I'm calling the shaping of technological choices by the profit motive and driven by, as Indranil pointed out, the fact that the public healthcare system withdrew from its responsibilities in large part, and even when it didn't completely withdraw, depended on private technological industrial supply for this. This is not simply a matter of, these examples are not simply vaccine examples. So let me give the example of diagnostic tests. Remember that the diagnostic test that is used universally, the so-called RT-PCR test, the reverse transcriptase polymerase chain reaction test, is a test and technology that depends on a fairly expensive instrument. There are far cheaper non-instrument dependent alternatives available. Yet, across the world, the overwhelming bulk of technological choices made to market virus detection methods ranged primarily at the high end, at the sensitive end, dependent on this instrumentation heavy RT-PCR test. And one is then forced to speculate that part of the imperative for this is driven by the imperative profit motive of the instrument makers, especially since large transnational umbrella concerns own both components. So that's one example. As far as the vaccine technologies are concerned, Prabir underlined this very much better than I did, which is that it's not simply patents that provide for exclusivity of manufacturing control. It is also the underlying know-how. Making mRNA-based technologies, making plasmid or DNA-based technologies, even making adenovirus-based technologies on large scale requires a certain level of tech absorption capacity in the industry that is dependent on fairly specialized know-how. That falls, as Prabir pointed out, effectively in the category of intellectual property, trade secrets, whichever way one wants to frame it. And all of those depend on that. On the other hand, the technology that is involved in, say, the Novavax vaccine, it's harder to develop but easier to scale up. The technology with respect to the Bharat Biotech Covaxin is very easy to develop, although it is harder to scale up. But it is harder to scale up not because the absorption is difficult, but because of the safety risks involved with scale-ups. So this is a complex landscape of trade-offs between technological ease, profits, and related issues. And in this, let me underline a point. All the current deployed vaccines that we are aware of, the mRNA vaccines and the adenoviral vaccines, which are the major categories of vaccine technology platforms, all of them, without exception, were developed for two major diseases over the past 20 years. One was Ebola. And Ebola, the vaccines were developed knowing that it was going to be vaccine colonialism, that companies in the global north were going to develop these vaccines and their governments were going to use them. And this is where the distinction between donations of export versus as an instrument of political influence versus straightforward commercial interests comes into play. Ebola vaccines were always going to be donated for ring vaccinations, for local vaccinations in affected areas in African countries. And that's why they could be at a very high level of technological absorptive background needs without any problems. And that's how they've been developed. On the other hand, the other way, especially for the Oxford AstraZeneca vaccine, those vaccines were developed again similarly, but this time for SARS and for MERS. And in all of this, there is, as I keep saying, a complex landscape of trade-offs between nationalist interests that are political, between commercial interests that are transnational, and the technological platforms involved. The rest I'm going to leave to Prabir.
Prabir, quickly, because we have to also
Jessup has
conclude
already
this
said
session
thank
and go
you.
to the next.
Jessup has already said thank you. So I'm aware of the, shall I say, the bottom line. Quick, okay? I'm going to be very quick on this. Essentially, if you look at it, India has really produced bulk drugs, not bulk drugs, what we used to call bulk drugs, but really generic medicines in large quantities for the international market, not competing with the patented medicine, which it has left, even though it is now trying to compete in that sphere. And vaccines are somewhat similar. We have really been on the generic vaccine market there for a large amount of vaccine manufacture, which takes place in India. And big multinationals are not interested in vaccines except for probably the flu virus. That's something they're interested in, not in the rest of it. So India and China, in that sense, have been really big players in this. India has big vaccine manufacturers. China has much more distributed vaccine manufacturing, but both have a lot of capacity for vaccine manufacture, and they have cheap vaccines they manufacture, sell to the international market, donate some of it. So the business model is really different. That's why the quantity is large, but money-wise, it's not. Money-wise, it's still a few of the big American companies or other European ones who seem to make the more profits, the high end of the market, but that's for another day. I'll leave it at that.